Hello everyone, my name is Dr. Anil Kamath. I am a senior consultant surgical oncologist at Apollo Hospital, Bangalore in India. Now, I would like to talk to you all about patients with the carcinoma of the lower part of the rectum. I would like to talk about how much we can stretch preservation of the sphincter. Say you have a patient with a tumor which is about 1 or 2 centimeters from the anal verge. Is this patient suited for a sphincter saving surgery? Now, traditionally, if this question was asked maybe 15 years back or 20 years back, the answer would have been that any tumor which is even 5 centimeters from the anal verge is not suitable and the patient will have to live with a permanent stoma. But that is not the case today. There have been many developments, many evolutions in the treatment where a patient with a tumor even 1 to 2 centimeters can from the anal verge become suitable for a sphincter preservation surgery. What are these developments? One development has been the use of neoadjuvant treatment. Now, for lower third of the rectum, almost invariably, most of our patients go for what is known as total neoadjuvant therapy. They receive the entire course of radiation and chemotherapy before we consider them for surgery. What happens when we give this is that certain patients respond completely. There is no residual tumor, and these patients can sometimes go for a wait and watch approach with no surgery at all. As many as about 20 to 30% of patients don't require surgery. The next thing is that the margins which you have to give after chemotherapy and radiation is much less. A tumor-free margin of about 1 centimeter from the distal tumor is enough, when especially in a post-radiation case. So that is another development which has happened. The next thing which has happened is the availability of robotic surgery. With robotic surgery, we can go so low in the pelvis that earlier it is greatly difficult even with laparoscopic surgery, and with open surgery, visualization of this area is just not possible. So we can do what is known as intersphincteric resections. So if we have a patient in which the internal sphincter is involved but the external sphincter is free, we can use the robo and go in between, in the plane in between the internal and external sphincters, so that we can do a oncologically safe resection. The colon can be brought down through the rectum and anastomosed through the anal canal. So with these advancements, we have been able to preserve sphincters as much as 1 to 2 centimeters from the anal verge. Having said that, I must also add that in few cases, sphincter saving is not possible. If the sphincters are grossly involved or oncologically safe margins are not possible, then these patients are not suited for sphincter preservation and they will have to live with a permanent stoma. The other problem with sphincter preservation is that a temporary diversion is required, and some patients develop what is known as low anterior resection syndrome, where they continue to have problems while passing stools. There can be incontinence of stools, increased frequency, sometimes pain. So all these problems may be there as a trade-off of sphincter preservation. So I would like to conclude that any patient where the sphincter is free, if it is 1 or 2 centimeters from the anal verge, can be considered for a sphincter preservation surgery. Thank you.